One growth stimulus that's important for muscle growth is mTOR. Leucine can actually, the man who discovered mTOR is David Sabatini. I got to hear him talk, really fascinating individual. But it's been shown that leucine can stimulate muscle protein synthesis. This is one of the things that's important for muscle growth. So when you exercise, that's one of the important factors which actually initiates the muscle growth. Not the only one, but one of the important ones. Again, muscle protein synthesis, the synthesis of new muscle. So it makes sense that stimulating that may have an anabolic role. The issue is that if you have an inflammatory state, such as cytokines, they actually can block the ability for those to even be effective. So if you're going to use something like that, it would probably make sense as a multimodal therapy to get rid of the inflammation for this to potentially have its role and fulfill an effect. It is something that is of interest for our lab because, again, it's a non-toxic approach that may stimulate that process. While if you do, like, let's say if we wanted to explore a ketogenic diet, because again, there's a lot of facets to a ketogenic diet that there's some evidence that's anti-inflammatory out of Deep Physics Lab, a Nature Medicine paper. Also, there's some evidence, 2004 and 2007 paper, showing that ketogenic diet may be slightly superior to a standard diet for lowering certain inflammatory cytokines such as TNF-alpha, IL-6, things such as C-reactive protein.
Hey friends, it's Mike Mutzel here with High Intensity Health. Thanks for tuning back into another episode. Today we're going to talk about cachexia with Andrew Koutnik. He's a PhD student here at University of Tampa, South Florida. We're at the Metabolic Therapeutics conference where Andrew gave a wonderful talk about cachexia, and we're going to explore that. He's a type 1 diabetic. As you can tell, he's a power lifter, weightlifter, so he really practices what he preaches. And Andrew, first of all, thanks for coming on.
Awesome, thank you for having me.
Really appreciate it.
Absolutely.
I think let's just talk about what cachexia is. I think a lot of people don't really understand, like all the different, heart failure, renal failure, cancer, different disease states, and how actually it's a factor linked with poor outcomes in these disease states, right? So let's kind of...
Right, yeah. So we kind of focus with cachexia from a cancer perspective, but it also is tied to these other diseases you mentioned, like COPD, chronic heart failure, kidney failure, also AIDS. And it's not as prevalent as it is in cancer in these conditions, but it does occur. And what's interesting about cachexia is a lot of times in a clinic, a physician may see someone losing weight. A lot of times you hear about patients who have cancer and they come into the clinic and the physician sees them losing weight and they get terrified of that. A lot of that may be founded in this idea of cachexia, because cachexia is founded with some really worse outcomes, worse prognosis, worse ability to tolerate treatment. A lot of times patients won't actually die from, let's say, cancer cachexia. They won't die from cancer. 20% of all patients who have cancer and pass away, they'll die from cachexia. So this is a really important problem, but unfortunately it's understudied, undertreated, but pretty prevalent. So in cancer, it can occur in a range of, it's cited that it can occur in a range from 30 to 80% of all cancer patients. And when you have advanced cancer, it could range from 60 to 80%. Advanced cancer meaning it's metastatic. That means it's moved from its primary origin, where the tumor originally originated, and has moved to a distal site. And when that occurs, the prevalence is 60 to 80%. And when we're talking about cachexia, and you asked this original question, what is it? Cachexia is what they call a multifactorial syndrome, which means it has many different facets to it. It's not one thing. It's not just weight loss, although that is prevalently what is seen in the clinic. So when people come into a clinic and a physician sees them, they're losing weight, they're immediately maybe thinking, oh, this patient has cachexia. But regardless, weight loss is just notorious for worse outcomes. It's also an inverse relationship with quality of life with patients as well. So it really hits on many, many outcomes that don't go in the right direction when you have this condition. But what is it? Some of the facets include anorexia. So when a patient has cachexia, they tend to eat less food. Their food intake is reduced, which would certainly play into the weight loss. Secondary to that is inflammation. This is one of the most important aspects of the condition, because inflammation can tie into not only the tumor, the muscle wasting, the lack of food intake. It's integrative to all those issues. And that has been a target for many therapies for this condition, is to target the inflammation because of how integrated it is to the other aspects of the multifactorial syndrome of cachexia, that it has been a focus. Not entirely, but that has been a focus of much of the therapies that are out there. So tertiary to that is metabolic derangement. You actually can get insulin resistance. So a patient is wasting, so you typically think, oh, I'm losing weight, my insulin resistance will be reducing. Well, in these patients, that's not the case. At least it's reported that it's not always the case. And that's probably tied a lot to the inflammation. And that when these patients are wasting with all these other things going on, they actually can get insulin resistance. They also get, and it's more probably appropriate to mention it as metabolic derangement, because it's not just insulin, you also have ghrelin resistance reported as well.
That's where the hunger cessation kind of stops, eh? From the ghrelin resistance partly?
That can play into it.
Yeah.
Another role into that is the inflammation. IL-6, TNF-alpha, these have both been cited, and they're commonly reported in cachexia. So these pro-inflammatory cytokines are what is actually much of the interest, and not completely, but much of the interest is tied into these two cytokines, because they're very common. They're associated with not just cancer cachexia, but many other conditions, and play a role, actually can go into the brain and reduce hunger. Ghrelin is a hormone that is more of an acute hormone, typically speaking, where, say, if I was on a normal diet, standard diet, and I was eating 3 meals a day, and I, let's say, ate breakfast, and I'm rolling up to lunch, and I hadn't eaten yet, and let's say I'm getting 2 o'clock, 3 o'clock, a couple hours past that, ghrelin's starting to get high, because it'll go to the hypothalamus and stimulate hunger, and it's an acute response. So whenever I eat food, ghrelin goes lower. When I haven't eaten for an extended period of time, and just in the context of, I just using me as an example, then it would be higher. And so it can acutely affect hormone levels. And there's been some reports in cancer that ghrelin resistance can occur, which may not mean that it's so much an acute hormone anymore, but it may be elevated chronically because the patient may have a level of ghrelin resistance, but then they're also becoming anorexic at the same time, or already were anorexic, and then that further exaggerates ghrelin. So your ghrelin levels just kind of creep up higher and higher. And something to keep in mind when it comes to cachexia, it's not like a patient may come in and they have all these conditions, like, when you have cachexia, you have all this. No, not always. It may just start with some initial weight loss, some lack of appetite, some metabolic derangement, and that's typically what characterizes the first stage of cachexia, which is actually called pre-cachexia. And then when you get to the secondary stage, but when you actually are defined as cachexic, that is when you actually start having reduced food intake. You've lost at least 5% of your body weight, and or greater than 2% of your body weight loss with a low BMI. I think it's less than 20 kilograms per meter squared, or you have been diagnosed with sarcopenia, and this stage is more associated with inflammation. When you get to the final stage, which is called refractory cachexia, which can involve varying degrees of cachexia or varying degrees of wasting, but typically more than what you'd see in the cachexia, which is greater than 5%, but when you get to refractory, it's typically obviously more, but it varies within that range. So there isn't a set definition for what that is, at least in the most recent definitions. In 2011, there was a paper from Fearon and a few other MDs where they sat down and actually discussed what would define this to help researchers pin to a target for assessing this condition. So, because if you don't have a target to go at as a researcher, you're just kind of like, okay, well, these are things that typically happen. You are shooting, but you're kind of shooting in the dark at many different targets without a bullseye, or at least a set of bullseyes that are important to go after.
Yeah.
But in that paper, the final stage of cachexia is refractory cachexia, and refractory cachexia is certainly considered the worst point of having cachexia, where again, varying degrees of cachexia, varying degrees of weight loss, but you are now refractory to antineoplastics, and typically it's believed that you are now going to be refractory to any possible treatment for the condition of cachexia itself. Usually this is in the last 3 months of life for the patient. So once you reach this stage, it's typically believed you're only going to be, unfortunately, allowed maybe 90 days left of your life, and it's believed that you can actually reverse that. Now, there is some data from Prado and colleagues who found that in looking at 700 patients, they found that there was a certain subset of all patients in the last 90 days where they actually were able to gain weight. 15% of those patients were able to gain weight. And what they looked at is they compared patients who were able to gain the most weight and the least amount of weight in that refractory time period. And they found that those who had gained weight had stable disease, and those who had, the top 5% who was able to gain weight had stable disease. And those who had lost the most weight during that period had progression disease, almost all of them but one. And so So when we talk about refractory cachexia, it is generally believed that there's nothing that can be done, but there's some evidence that maybe you can if you can get disease stable. So yeah, that's that, and that all these conditions, whether anorexia, inflammation, insulin resistance, or metabolic derangement, anemia is another one, where it can be characteristic of biomarkers low, like low hemoglobin, low hematocrit, low red blood cell count, which can then tie into functional impairment as well, which is important with the patient. Ultimately, with this condition, the most important aspect is a loss of muscle tissue. And actually, when they define it, they're defining it as a multifactorial syndrome with the loss of muscle and/or fat. So you don't necessarily have to lose fat to have this condition, although it usually does occur with it. We currently are looking into model systems. We have developed a model system over the last 2 years to truly try and emulate the disease in its most prevalent condition, which is when it's metastatic. And so we have a model of metastatic cancer that systemically metastasizes from the primary tumor to systemic regions throughout the body. That includes the liver, the spleen, the kidneys, other areas throughout the body. And what's interesting is that we have found within this model that it has all the characteristics we measured of cachexia, and we think that's important to study it in that condition when it's most prevalent. So that's something we're trying to work towards, and now we're trying to study some of the therapies we think may work. We don't know yet, but we think may work in this model system, and then we'll see from there. But that's where we're currently at, is testing those different therapies that we hypothesize may work, may not, but to be seen.
Yeah, we'll dive into some of those therapies and kind of where you're going. But I think to kind of back up and summarize, it sounds a lot to me as though this inflammatory mediated metabolic derangement leads to muscle loss, right? And then kind of the crosstalk from muscle to other organs. I think you termed it yesterday multimodal, right? Where muscle is communicating with the rest of the body, and then that's where we see this high increase in mortality at the later stages.
So multimodal refers to the approach I think is necessary to treat the multifactorial syndrome. When you talk about the metabolic derangement, the insulin resistance, and the inflammation that's involved in that, higher levels of inflammation are definitely associated with a level of insulin resistance. It's necessarily going to always be the case, or there's not like necessarily something like perfect, like, okay, this inflammation happens, you're going to get insulin resistance. Not necessarily, but it's something that is reported in this condition. We know that inflammation is in fact a part of that, but inflammation plays many roles in this condition. The TNF-alpha, IL-6 go to the brain, can affect hunger. TNF-alpha, IL-6 can go to the muscle and actually cause degradation of, so when you at the muscular level, so we talked about some of the appetite there, but at the muscular level, cytokines, pro-inflammatory cytokines can actually come to the muscle and actually not only induce catabolism of the muscle, but reduce synthesis of the muscle. So it's generally believed that on a day-to-day basis, you may be breaking down some muscle and then resynthesizing muscle on a regular basis. So you have this constant cycle.
Right.
Well, let's say that this is synthesis and this is catabolism, and you have this imbalance all the time. And let's say that you're trying to put on muscle and you include more protein, you work out more, and you may be tipping it in this balance. So you have this net difference that you're adding muscle. But let's say that in this condition where you have cytokines that are elevated and maybe you're reducing your food intake, catabolism goes much higher with these cytokines, and they also reduce the ability to actually cause muscle protein synthesis. They act as almost like a blunter of that response. And so now your net balance is in the opposite direction, and you have this big differentiation in causing a net muscle loss. And that plays into it. So not only are you in a caloric deficit, you're not hungry, but you're also having the same exact things that may be causing hunger problems to also inhibit the ability for the muscles to not only synthesize, but exaggerates catabolism. And at the tumor level, we know that like when the tumor is present, and this is obviously a tumor-induced disease. If you didn't have the cancer, then you probably wouldn't have cachexia. There are conditions where you don't have that, but in general, you have to have the disease to have. You have to have the disease to onset this cachexia syndrome. So the tumor has to be present, and the tumor itself, the body may see this tumor as foreign. Usually, it comes from our own tissue, so it may not completely see it as foreign. But let's say it does see some type of abnormality with that tumor. Well, your body may mount an immune response towards that and cause the liver to cause an acute phase response, which may cause some elevation in inflammation. But the tumor itself can excrete inflammation markers as well. So it could be both ways. And so it kind of like how I view this is you have a tumor that is integrated not only into the muscle wasting directly, it goes both ways. So muscle wasting, not only the tumor's only inducing some level of muscle wasting, maybe it's just stealing nutrients, but then the muscle wasting itself may exaggerate tumor growth, whether it's because you can't do as much treatment. There's actually some evidence that for those who have muscle wasting, that if you give, let's say, chemotherapy at a specific dose per body weight, you may actually get a higher level, what they call area under the curve of the drug, such that when you take this drug, it's actually elevated beyond what would be expected in the blood for, I don't know if it's longer periods of time, but it's definitely the absolute elevation of that drug in the blood is higher. So there seems that the muscle either plays some type of buffering of that or is doing something that I really don't know. But it seems like the drugs are more potent in people who don't have as much muscle. So then you can't tolerate the drug as long. So you can't give the full antineoplastic treatment, and then that may exaggerate toxicity. And so you're not able to respond to the treatment because you can't do it as long. You can't tolerate the treatment because it's becoming more toxic. Ultimately, you probably won't respond as much to the treatment as well. And so I think it's important to mention that the muscle is not just an important functional thing we use every day when we walk around and move, but it plays a pretty, it's its own organ system that plays a pretty integrative role to many other aspects of the body. There's crosstalk between the brain and the muscle, with white fat in the muscle, brown fat in the muscle, the liver in the muscle.
Pancreas muscle, right?
Correct. Yeah. So it's and that's when we talk about with the body. So that's a lot of times when there's, as a researcher perspective, a lot of very basic science does cell culture work. And a lot of times there's drugs tested at the cell culture level. There's a certain expectation that a lot of that may not translate, only because there's so many other things that are integrated. So that's why it's so important when you go from cell culture level to then use an animal level. Because now you don't just have, so a lot of times in cell culture you're using the cells that you're specifically interested in. But when you move out of, or you want to elevate to the next level, you want to use a system, let's say a mouse or a rat, where they have all these other organ systems that replicate a lot of what humans see and their physiology. And that allows you to use these therapies. Say if you want to test a therapy or even see what a mechanism is going on, it allows those other integrative systems to be there when you test whether something is or is not working, or to see if a mechanism, how it works. So every step you go up in a higher level, you kind of expect some differentiation and response, or at least you hope there wouldn't be, right? Because if you're going from a therapy you think is going to work in cell culture, you hope it's going to go to the next level. But oftentimes it doesn't always translate the same way, because there's so many other factors involved. And that's what I talk about with the crosstalk with all the other things. Because I try and look at it from a muscle-centric, or at least a lot of what I look at it from cachexia is muscle-centric, because that's the most important component to it, is that you have that loss of muscle tissue. But there's other things that are obviously contributing to that and or have their own negative side effects, such as the inflammation that are involved in that.
So it kind of sounds to me that there's like peripheral influences on skeletal muscle, but then once the disease process starts, it's almost like then a feed forward, like a snowball rolling downhill, where the muscle kind of gets sick and then it's sending messages from the systemic to the rest of the body, right? Is that a little bit?
Yeah, so and I think that's a good way to kind of look at it, is once the disease process initiates, there's kind of this process where you're trying to target. So let's say the initiation of it, let's say we talk about pre-cachexia, if I frame it in these stages, you may have some little initial body weight. So let's say you're losing some muscle here, you're losing some fat here, you're losing some of this important tissue that may play a role in buffering some of the consequences of the disease itself, and then you're starting to see some metabolic derangement, which is now going to exaggerate some of the the loss as well, right? It can certainly contribute to that. And then you're probably going to have a reduced food intake because of many of the things that come along with that consequence. So reduced food intake, we know, is going to affect functional tissue loss. It depends obviously on certain diets. You may the spectrum of how much fat to muscle loss. You're probably going to lose both, no matter what you do in your caloric deficit. But certain diets certainly shift that to a certain one spectrum or the other, whether it be fat, whether it be muscle more so. Like, for example, if someone's been on a ketogenic diet for an extended period of time, they may lose higher proportions of fat whenever they lose a tissue, whereas if that may be less so in a diet that isn't as grounded in super high fat and lower of the other nutrients. And your body seems to adapt to whatever you give it to it for the most part. We're very good at adapting to different stimulus. So if we give it new food, different proportions of food, we seem to be able to preferentially shift towards the foods we're giving it. And that makes sense, right? We're just adapting to our circumstance. We're sitting outside here and the sun is beating down on us, and if, that's only a acute period of time, and it's shady here, but say we were out in the sun on an extended period of time, we may get tanner, or our body's just constantly adapting that process. So say we were outside all the time, if I'm out in the sun for an extended period of time, that can drain my energy a little bit. I try and get outside and experience the sunlight every single day. Just to get out. And a lot of times we can be in the lab, so we may not be out in the sun a lot, but I try and experience that every single day. But if I were to spend the entire day outside, it may beat me down. But if I'm outside every single day for extended periods of time, I might adapt to that. So like anything, your body is a very good adaptive machine. So.
Really awesome stuff here. One thing that's come to mind, I didn't want to interrupt you, but TNF alpha, you mentioned, this inflammatory cytokine used to be called cachectin back in the 1950s.
Yes, it was.
So that is really fascinating to me, that researchers have kind of known that this inflammatory cytokine that's well recognized, initiates or causes or is involved with the loss of muscle.
Yeah, so when I was first introduced to this, I was introduced that cows that would get sepsis, they would waste, their body tissue would waste away. And what they did is a researcher isolated out the fluid from the animal and found that there was high levels of a certain molecule, and then at that time was called cachectin, and later called TNF alpha, because there was research over here showing this molecule had an effect, and then over here in this research on the cow with sepsis had a differentiating effect. And so now it's called TNF alpha, but it was at one point called cachectin for that reason in sepsis. What's interesting, bringing up the idea of sepsis, is that cachexia is a unique form of weight loss. So when people approach like, I'm doing a caloric restriction, or I'm fasting, or let's say I'm just trying to exercise to lose weight, or whatever they may be doing, that's a very different type of weight loss than cachexia is. The things that are, the facets that contribute to that weight loss are very different. In fact, normal healthy weight loss or caloric restriction is anti-inflammatory, has many health benefits. Again, within context, if you're losing weight and you're already super low in body weight, maybe not, but let's say that you're slightly overweight and you want to lose weight, that has many good properties for your health. Whereas cachexia, it's a form of weight loss that's very distinct from that form of weight loss. And the inflammatory component between cachexia and, say, just normal caloric restriction is very different. One is more tied to anti-inflammatory, and one's tied with pro-inflammatory. And a lot of what we see as far as weight loss, if I were to try and replicate any form of weight loss associated with, like, let's say, caloric restriction, fasting, hyperthyroidism, sarcopenia, all those have some of the aspects of what cachexia has, but not all of them. The one form of weight loss that seems to replicate the most amount of syndrome, the facets of the condition, is actually infection, where some level of underlying chronic infection seems to replicate many of the facets of what we see in cachexia. So I was actually talking to a gentleman the other day who had a low-grade level of inflammation that they thought was cancer at first, because he was kind of losing weight chronically, not voluntarily. He had told me 50 pounds. And it was interesting hearing this story, because what does that mean? But it's still interesting to hear the story and hear this. I actually had not heard this from a patient who just had pure inflammation, and he had an issue with his spine, and that had induced a level of chronic inflammation, and he was losing weight. He had lost 50 pounds, and his doctor was doing tests, and every blood test came back, and nothing they tested could indicate he had any level of cancer. But what he did have is an underlying level of inflammation. They gave him antibacterials, or not antibacterials, antibiotics, and I think he did some other type of anti-inflammatory, and it cleared his condition. His weight loss stopped. Now, granted, I'm not saying that, this gentleman represents all the cases I'm trying to say, but it's just interesting to hear that story. And but the evidence indicates that if you just look in the literature, that infection seems to replicate fat loss, muscle loss, body weight loss, and high levels of inflammation, metabolic derangement, possible anemia, possible hypoalbuminemia, so low albumin, because the liver may be prioritizing other processes in the body instead of producing sufficient albumin, although it could be for differentiating reasons. But what's interesting about this condition is there's so much going on. The underlying pathology is not completely understood. And so there's certainly a lot left to be known. I think anytime a researcher says, this is what we do, there's so much left to be known, I mean, that's the default answer. There's more to be known. We do know a lot. and I think there's a lot that we could use off what was already known to try and develop effective therapies. Because there's been about 100 clinical trials with cachexia, no standard of care at this point for it. Interesting, Megase, progesterone, which stimulates appetite, has been approved for AIDS cachexia, but there's nothing for cancer cachexia at this point. And there is SARMs is an interesting anabolic agent that has been
like a peptide world kind of thing.
You can kind of integrate that thought process into there. SARMs is a selective androgen receptor modulators. How I describe it is how I was introduced to it. So I was always in the fitness industry and the bodybuilding community. I know when SARMs first came out, and within the context of being used in patients like this, so you always see people getting hyped up about drugs like this, but they usually come because people they start to find out about them because they're finding out about them because people are studying them for other health ailments. They're like, oh, could we use this? Bodybuilders, not all bodybuilders, but a lot of bodybuilders who take it to the extreme level, they want anything and everything to give themselves an advantage for their muscle growth. And I understand that mentality. I was right there in that same place when I was younger. But SARMs, when it was first introduced, it seemed like this potential golden bullet drug. Like you could get all the benefits of testosterone without having the side effects of testosterone because it's specific to the muscle, the muscle tissue. But in healthy, so let's say it doesn't seem to be this massive, overwhelmingly powerful drug. However, in cachexia patients, it currently has passed. There's some SARMs that have passed phase 2 trials, and we're waiting to hear back about phase 3 trials. Currently, now this is early February 2017. So, and the reports are supposed to come out any day now. So we'll find out about those. We'll see. Hopefully, it passes and works. So patients now have some type of anabolic agent. And I guess that kind of introduces the topic is what type of therapies are out there, or what type of therapies have been explored for this condition.
Let's. I definitely want to talk about that, but there's a few things that I'll forget. We want to go there for sure, and I want to finish up the SARMs thing. But to me, it seems like this there's a spectrum. Sort of like if we look at like functional medicine, or from total like normal glycemia to pre-diabetes, diabetes, and so on. It seems that like is sarcopenia on kind of the pre-cachexia stage, or is that a different metabolic disease?
It was definitely different.
Okay.
It doesn't have all the facets of cachexia. Cachexia seems to have more facets to it. It's interesting, like in sarcopenia, you do lose muscle tissue. That's the clear similarity there. You do lose body weight, typically. Fat loss doesn't necessarily have to come along with it, which it could be seen as a similarity because you don't have to have fat loss to be considered cachexic. So you can have sarcopenia but be obese. Same thing for actually cachexia. You can actually have wasting of the muscle tissue while still being overweight and obese. There's actually some interesting cross-sectional images of human patients where you actually see the muscle shrinking over a period of time, but their overall body weight appears to not have shifted that much, maybe just dropped down a little bit in weight because the adipose tissue is maintained. That's actually considered for worst outcomes, where the fat is still prevalent and the muscle is just wasting away. And that can happen with sarcopenia as well. Inflammation can play a role in sarcopenia, but low albumin levels, anemia, hypogonadism can be associated with sarcopenia, but also associated with cachexia. But there are distinguishable factors. It doesn't fit all the multifaceted characteristics. I'm less familiar with the metabolic derangement in sarcopenia, if that is or is not a factor. If I imagine if a patient has inflammation as a sarcopenia patient, I'm just speculating here, they may seize that problem. I'm not sure. But that doesn't mean that the therapies that work for one may have application for the other. And so
really interesting stuff. And what I find very fascinating is positive stimuli like exercise also increase TNF-alpha and interleukin-6 within the myocyte, right? And so you're like, wait, so exercise is healthy, it's a positive stimulus, it increases the same cytokines or myokines, whatever you want to call them, but then we have this chronic disease state so it's kind of like, is it the context of the cytokine environment, or is there a different signature? I think that's really hard for people to wrap their head around.
Right, so this is how I describe all of that, and I think that just expands way beyond just this question here, is when you're talking about chronic stressors. So let's consider TNF-alpha and IL-6 a stressor, all context dependent. So when you exercise, some people may view that as a stressor, but it's a short stressor. it lasts for a short period of time. And it seems like those type of stressors are good for you. An acute stressor seems to be good for you, whether it's exercise or just moderate stressors. But if you have, or like, let's say exercise increases your blood pressure, increases your heart rate. However, if your heart rate is elevated all the time, if your blood pressure is elevated all the time, that's not necessarily associated with health. So it's just to distinguish between these acute stressors and these chronic stressors. Exercise is good, but let's go say we go run for 24 hours straight, or we do excessive amounts of exercise every single day. Is that considered good?
Right.
Probably not. And so any of these things, when we're talking about doing something that may be good for your health in excess, it's in so much what we call, it's in the dose, right? And that applies here too, when you have acute elevations in these molecules is important. In fact, there's evidence to show that if you inhibit the pro-inflammatory process of exercise, you reduce the ability for the body to adapt to that process.
Like taking antioxidants post-workout maybe?
Correct, yes, yep. That's actually what has been done. And it seems to blockade some of the aspects of the adaptive process. So it definitely is a distinguish between someone being able to have a chronic versus a short stressor. And that seems throughout life, right? So if you're working really, really hard and you're starting to, you have a job that takes a lot out of you, that may not be if you're just having a short period of time, like, okay, I'm standing up to do this presentation, I'm a little stressed out, that's okay. But if I had to feel that every single day, no bueno, not good for you, right? And so I think that when we're talking about stressors or things that can be considered stressors, even healthy things, in excess for chronic periods of time start to play negative consequences. Like type 2 diabetes, a lot of that seems to be similar overlap there, and a lot of these things you see with, and diseases like that, it's like these things that a lot of I guess the best way to describe it is still the blood pressure and heart rate perspective. It's just these things that if you have them for a short period of time, there's not really that, it's good. It can actually be good for your health. Certain drugs actually that have been associated with positive health outcomes in patients are acute stressors. And so that can be good, but doing that over a long chronic period of time, that's probably not as good. Like caffeine, I'm certainly no expert on caffeine or its metabolism or anything like that, but I do know there's some evidence to indicate that if someone is a fast caffeine metabolizer, the caffeine can be good for your health. But if maybe you're a slow caffeine metabolizer, maybe it's not necessarily as good because it lingers for longer. And who knows, maybe that has been debunked at this point. But I think in general, a good way of viewing this is that if anything is there for a short period of time, and it's considered a stressor of sorts, that's okay. But if it's going to linger around for a long period of time, it might not be as good anymore. And now may parlay a level of stress your body may not be able to adapt to, and it gets overwhelmed. Just like when someone has type 2 diabetes and short blood glucose elevations, okay, we can make the argument that it's probably better to have those minimized as much as possible. But if you're able to calorically maintain your body weight and you don't have metabolic syndrome and or type 2 diabetes, that may not be the worst thing in the world to have that. But if you have chronic elevations in blood glucose, chronic elevations of inflammation, you're overweight or whatever, so or you're constantly in a caloric surplus, those things may not be the best. That's why things such as caloric restriction for short bouts of time may be good. But even taking that to the extreme may not be good. Maybe you are in such a caloric deficit that your body is just like, let's say, the world I used to be from, like bodybuilding fitness community. I've done this myself. I went from 270 pounds all the way down to 218 over an 8-month period of time. So I tried to do as slow as possible, lose no more than 2 pounds a week, although not always ubiquitous that it happened like that. But I remember I got a DEXA scan about 2 months prior to me ending my diet, and I was around 8% body fat via DEXA, so DEXAs aren't always 100% reliable. They're good metric though, and for body composition. And I still dieted for 2 more months. And I remember I stood up at work one day and I fainted one time because postural hypotension.
Adrenal, maybe, stressful.
Possible. Who knows? But I do know the blood pressure when I stood up, it tanked, and I would have that problem. I would also be standing in a house at 78 degrees, which to me, I would have sweat.
When you were heavier?
Normal body weight, I would have sweat. And now I was sitting in a house freezing at that body weight. So I imagine this is not something associated with health.
Right.
It's something I wanted to do. You know, I kind of was an extremist and can still have some issues with being a little bit of extremist at times. But again, a little bit of caloric restriction has been shown to be really good for your health. But maybe taking caloric restriction so extreme to the point where you lose so much body weight, and it's all context dependent, right? But it cannot be as good. So to answer your question, kind of belabor that point.
Yeah.
Acute stressors, not so bad. Long stressors, chronic stressors, bad.
Right. Yeah. Really good point. And I want to definitely cap off our discussion with SARMs and some of the treatments. But I think a nice kind of segue there is to talk about some of the mediators involved in like muscle protein synthesis, mTOR,
Right.
things of that sort. So let's talk about, we talked about the bad stuff and cytokines and TNF-alpha and whatnot, can kind of break down muscle and lead to this cachexia, sarcopenia, and so on. But what are the other positive signaling molecules that we know about?
When you say positive signaling,
I mean, like that are beneficial to rebuilding muscle, maintaining muscle, maybe that are involved like post-workout. You know.
Right. So honestly, growth signals.
Yeah.
Which, for example, you have acute elevations in certain hormones associated with growth, which can scare people in the context of treatment for cancer, because a lot of those same signals are what stimulate in the cancer growth. So you got to be careful when we start talking about cachexia, because there may be some benefit to the muscle, but maybe that same thing is elevating growth in the tumor. So there's actually been some studies on insulin in cachexia patients, which insulin we know is a really potent growth stimulator in cancer, IGF as well. And in the context of, let's say, post-workout, that'd be great probably be good for anabolism of the muscle. But so you have to be careful with those differentiation of what may be an ideal therapy for the cancer, also ideal therapy for the muscle. So I guess it kind of segues into, I guess, these categories of treatments for cancer cachexia. I like to categorize them into 4 different categories. It certainly doesn't encompass all of them, but I just kind of a simple way of doing it is nutritional therapies, appetite stimulators such as anti-anorexics, anti-inflammatories, and the last aspects are like anabolic agents. So for nutritional therapies, one of the things that's been the most the most commonly advised thing from a doctor if you're losing weight and they're scared about you losing weight because of the prognosis that comes along with that, is just to eat more calories. That's also a lot of what goes into the appetite stimulators, the same concept. You eat more calories. That's the goal of both those treatments. The problem is that when you do that, more often than not, you aren't necessarily completely salvaging the muscle. You're definitely not growing the muscle. There's a lot of evidence to indicate that when you over-consume food in a cachexic state, and this is common not just in cachexia, this is a normal physiology. If you're over-consuming food, you're going to probably put on a disproportionate amount of adipose tissue, and that's what we see in cachexia as well. So when you overeat food, what you actually are putting on is mostly fat. There's some evidence that you still lose muscle while putting on fat, and there's also some evidence that you actually may be able to maybe stop the muscle wasting, but you're still putting on a decent amount of fat. So usually if you're stopping muscle wasting, you probably have put on a decent amount of fat to at least mitigate that loss in muscle. So what's your plus and minus there? Like does the negative outweigh, or the positive outweigh the negative there? I don't know. The second nutritional therapy is higher protein diet, which does make some sense, right? So protein is the substrate that would be used for building muscle. And also important for wound healing, enzymatic activity. It has an important role in the body. But there's just not enough evidence to necessarily show that it's going to be extremely effective. Doesn't mean it shouldn't be recommended. I'm not saying that by any means. I'm just saying that currently the literature doesn't have an overwhelming amount of evidence to say it's actually going to prevent the cachexia in the patient. Yeah. So that kind of encompasses nutritional therapy. Then you get back to anti-anorexics, and there's one big category, the most studied drug category is progestins. Progesterones are derivatives of that. The most popular one is MGAs, the one I've mentioned that can work for, has been approved for AIDS patients who have cachexia. This is a drug that stimulates hunger, does so effectively. There's some reports of it has some negative side effects. So it's not this like perfect drug to just be there whenever you want to stimulate appetite, but it's been in 80 to 90 clinical trials at this point as of this time frame. And now it's usually added to other therapies because what we find in cachexia is that monotherapies don't work. You need a multi-model approach to a multifactorial syndrome. So that's progestins. Then you get ghrelin mimetics, so things that could mimic ghrelin in the body, as we talked about ghrelin before,
Right.
and its ability to stimulate appetite. The positive side of that is if you can give this, there's not, from what I'm aware of, too many negative reported side effects, although I'm sure there is with anything. There's nothing without consequence almost ever.
Yeah.
But if you can mimic ghrelin, you could potentially mimic hunger. The con side of that is that there's enough to cause it to be, there isn't enough evidence for someone to prescribe ghrelin mimetics. But there's also a level of ghrelin resistance in patients. So is it really something that you want to, would it be effective when there's already ghrelin resistance? Probably not. At least the common sense would say no. But maybe, so there's ghrelin mimetics there. And there's some other things such as corticosteroids that can stimulate appetite, but it's usually not the primary use for corticosteroids, and there's a lot of side effects associated with that. So anti-inflammatories are another category of drug therapies that I usually mention. The first one is corticosteroids. It obviously is an immune modulating drug, and it can have the positive effect on appetite, can improve quality of life, especially if you're negating some of the symptoms of the disease of cachexia. The only issue is that the side effects of that is like elevating blood sugar,
Right.
which could have consequences on the tumor. If you look up side effects to corticosteroids, you can find a day's worth of information to read through. But they do have their place, but they're certainly not something that you would want to have to use unless you had to. NSAIDs are also used, non-steroidal anti-inflammatory drugs, such as ibuprofen. These have been used, but I think it's probably makes sense that patients have probably used NSAIDs before to treat some type of pain or something like that. You just don't see the reversal of the condition, but commonly these are used with other things as like a low anti-inflammatory aspect to a multi-model approach. So again, not enough evidence to support either of those that I have mentioned for anti-inflammatory use. There's also some antibodies that are being studied for removing TNF-alpha and IL-6. Interesting, right? So we don't know, those haven't progressed far enough to know if they will work or not, so we'll wait and see. And some interesting drugs, thalidomide, I know I'm butchering that name, but it can lower certain pro-inflammatory cytokines, and actually has been shown some evidence to enhance T-cell function. So these are some of the anti-inflammatory components, but again, none of those are prevalent enough to be prescribed. One interesting anti-inflammatory and one focus of our lab is to have non-toxic therapies. That's a big push in our lab, is to find non-toxic therapies for these diseases. And one anti-inflammatory that fits that criteria is omega-3s. Omega-3s should be a part of any normal healthy diet, whether it be a normal diet, whether it's high carb, low fat, probably supplement with it, or high fat, low carb, and maybe it's already enough in the diet to get sufficient amounts. But having omega-3s has anti-inflammatory properties, maybe some evidence that it may have some anti-tumor properties, and also has some anti-catabolic properties. So it kind of fits as multi-model. It's a monotherapy that maybe has multi-model aspects to it, so that could be really powerful. And it's non-toxic, but there is not enough evidence to support that it would be extremely effective at attenuating cachexia syndrome. But it is something that should be considered when integrating it into other systems. If you're going to do a dietary therapy, it would make sense to have that as an integrative component. And I will say that supplementing with omega-3, something to keep as a caveat, is that a lot of omega-3s, when just taken over the counter in pill form, aren't bioavailable. There's a lot of evidence to indicate that. And so a lot of people who use it for cachexia, they usually use the prescription-based one that is more bioavailable. But a lot of them over the counter aren't as much. So maybe getting it out of your diet is a better way, because you know it is bioavailable. You know it's a part of the food. Instead of trying to supplement with it when you don't know if that's actually bioavailable. You don't know how long it's been on the shelf and if the fats have oxidized or whatnot.
Yeah, there's some really good like monoglyceride and triglyceride-based omega-3s that are coming out that are a little bit more. But it's interesting. So in healthy humans, there are some clinical studies where they're randomized, and there's omega-3 users versus non-omega-3 users, and they do just aerobic exercise, and there's a more fat-burning and better muscle-sparing effect in the omega-3 users. So I think that's interesting. But you talked about amino acids. One in particular, leucine, has been talked about quite a bit in the branched chains. Any research? I mean, it doesn't have to be specific to cachexia, but how does leucine really work to increase mTOR and affect all that?
So that gets into the next category, anabolic agents. And I wouldn't necessarily call leucine an anabolic agent, maybe a nutritional anabolic agent. But leucine So one growth stimulus that's important for muscle growth is mTOR. Leucine can actually, the man who discovered mTOR is David Sabatini. I got to hear him talk, really fascinating individual. But it's been shown that leucine can stimulate muscle protein synthesis. Some rat studies out of Dr. Lehman's lab and Dr. Lane Norton's show that bolusing with BCAAs over periods of time can actually induce some level of muscle growth. That's actually a recent paper that just came out, I think maybe this year or late 2016. But we know it stimulates muscle protein synthesis. This is one of the things that's important for muscle growth. So when you exercise, that's one of the important factors which actually initiates the muscle growth. Not the only one, but one of the important ones. Again, muscle protein synthesis, the synthesis of new muscle. So it makes sense that stimulating that may have an anabolic role. The issue is that if you have an inflammatory state, such as cytokines, they actually can block the ability for those to even be effective. So if you're going to use something like that, it would probably make sense as a multimodal therapy to get rid of the inflammation for this to potentially have its role and fulfill an effect. So there may be a spot for that. There is some animal data that has shown some positive effects for BCAA use, but it has been limited. It is something that is of interest for our lab because, again, it's a non-toxic approach that may stimulate that process. While if you do, like, let's say if we wanted to explore a ketogenic diet, because again, there's a lot of facets to a ketogenic diet that there's some evidence that's anti-inflammatory out of Deep Physics Lab, a Nature Medicine paper. Also, there's some evidence, 2004 and 2007 paper showing that ketogenic diet may be slightly superior to a standard diet for lowering certain inflammatory cytokines such as TNF-alpha, IL-6, things such as C-reactive protein. But those papers were also confounded by weight loss. Weight loss we know does that too.
Right.
So it's really hard to flesh out if it truly is the diet itself or is it the weight loss or, But on the leucine front, so if you're doing a diet like that, you don't have as much protein intake. Maybe there's some benefit to doing that, but it's hard to say at this point.
Yeah.
And if a ketogenic diet with BCAAs is going to really stimulate mTOR. Because one benefit to the ketogenic diet that makes a lot of sense for potential cancer use is it downregulates a lot of growth signaling. And so maybe so when we talk about muscle, it's an interesting concept that I know we've talked about before, that may not make sense at face value, but may actually address many aspects of the multifaceted syndrome, the inflammatory syndrome, the muscle wasting syndrome. There's some evidence to indicate that a ketogenic diet, or even like this idea of fasting, that once keto bodies are present, there might be a muscle sparing effect in a catabolic condition. But again, I'm not saying that that's superior to a different type of diet or anything like that. I'm not saying that. But what I am saying is that it's worth exploring. I will say that at the very least. I feel very confident in saying it's definitely worth exploring, and it potentially has a role. But so you just talked about leucine and mTOR, and that's also part of how insulin works. So insulin can initiate can result in mTOR activation as well. So mTOR does play an important role in muscle growth or stimulating the synthesis of muscle. And again, you have this constant catabolic anabolic response. But another interesting part, so we talked about SARMs, androgen receptor modulators, and we're waiting to see what happens with those. Another thing that's been tested is testosterone. Hasn't actually been effective. It's reduced fatigue in the patient, but it hasn't actually effectively attenuated the condition or the body weight loss, or I don't think it's actually shown to attenuate muscle loss, which is kind of fascinating. You expect it to work.
Absolutely.
But maybe it's the way they did it, maybe they underdosed. I don't know, but it just the evidence isn't there for that yet. And they've actually used insulin before. I know I had mentioned that earlier. And there was one other aspect of anabolic agents, myostatin. So myostatin is and whenever you introduce this, you always think about these Belgian blue cows that have myostatin negative, they're jacked, or the whippets that are super jacked. And because of that, obviously, again, bodybuilding world's super interested in that. And so that's how I got introduced to it at first, that if you inhibit myostatin, you may have some growth process, because if these animals are defective or don't have myostatin effectively working within the body, then wow, maybe if we inhibit that, we can induce growth. The only issue with that is that that may have effects on the heart too. But in cancer patients, myostatin is upregulated. So myostatin works by inhibiting growth at the muscular level, but myostatin, so it's upregulated in cancer patients, which could exaggerate
the muscle loss.
Right, it can exaggerate that because you're further inhibiting muscle growth potential. But what's interesting about myostatin is it would seem to be independent of the tumor aspect. So if you can, and there's a lot of really positive preclinical evidence on myostatin inhibitors. It depends how you do it. If you antagonize the actual receptor itself, if you if you do an antibody for myostatin, so there's different ways people are trying to approach this. I think the actual receptor is ActR2, but don't quote me on that, but I think that's it. So try to antagonize that receptor, or they use an antibody for the myostatin itself. Preclinical evidence looks super supportive, and that it may have a really promising potential. But I think myostatin kind of gives an example of how we might want to approach cancer therapy, because myostatin would theoretically have very little effect on the tumor. It would be more specific to the muscle, which is where SARMs also have great potential, is that they seem to be specific to the muscle, and maybe not so much on the tumor. And so in that way, you can not have the negative side effect of a therapy from the tumor perspective. And it also kind of gets to this point of like, what would be an effective therapy? I think the first criteria for an effective therapy is that you want to be non-toxic or acceptable level of toxicity. When you talk about drugs like this, it may not always be, when you have a condition that has such overwhelming consequences, it may be acceptable to have some level of toxicity, but ideally none would be preferable. So when you're looking at a therapy that would be effective, what you want to have is something that is going to have a minimal or hopefully none, but an acceptable level of toxicity for what the patient is dealing with. So in cancer, the threshold for toxicity goes higher and higher and higher because the consequence of cancer and the treatments that are currently available
lethal. I mean,
go ahead.
that's it. Right, I mean, you're talking about life or death at that point.
Right, and so you can accept some level of toxicity or a lot of toxicity in that case. So drugs that would never be approved for other conditions may definitely get acceptance within the cancer world. And a lot of the therapies currently for cancer, mustard gas was actually one of the first original chemotherapies that were ever developed. And obviously, if you think about mustard gas, you probably would never think, oh, I'm going to give that to myself as a therapy. So yeah, the threshold for acceptable toxicity is much higher in cancer. But ideally, we want to go as low as possible on that spectrum. It's likely very important that you want to negate the inflammatory aspect of the disease because it plays so much into all these aspects that if you can get rid of that, because inflammation may even inhibit the ability to put anabolic agents at the muscular level because you have such an overwhelming amount of catabolism or inhibiting the muscle protein synthesis itself. You want to have something that is going to either have a positive benefit on muscle growth or just attenuate the loss. And that could be looked at specifically at attenuating catabolism or promoting anabolism or a combination of both. Ideally, both would be better. You want to consider the food intake of the patient. So it can't be ignored. I know caloric restriction has its place in potential anti-cancer therapies. But we must keep in mind that cachexia itself can actually cause death and is a comorbidity with this condition. It is its own disease. So we can't ignore it and think, okay, we're just going to calorically restrict until we get rid of the tumor and just completely forget that it may have a consequence in exaggerating it if someone has cachexia. Again, these are two distinct forms of weight loss, but one may exaggerate. So if you have cachexia and you're further caloric restricting, you're going to exaggerate your condition.
Yeah.
So you want to be careful with that. So I would say that you want to, if you're going to calorically restrict, you only want to calorically restrict to a level of body weight that is healthy and maintainable. At least that makes sense.
Right.
And it may be, I don't know, but it may not be the best to go too low on that and just try and push the anti-canceral threshold. But maybe there's a point of homeostasis with all this where you can keep things static on the tumor level and maybe push some ability to keep your muscle stable and kind of maintain that homeostasis. A lot of the therapies now are all-out blasts onto the cancer, and so those haven't been very effective. And so at working long-term, so you may have an initial really drop in tumor, and you may be, from an ecology perspective, you may be say you have this heterogeneous tumor and chemotherapy knocks out all but like this subsection. Well, now the subsection that was resistant to chemotherapy has all this room and nutrients to grow.
Yeah.
And so this resistant population may grow up and take over. Again, a lot of that that seems to be the case, and it's definitely a theory that's currently out there. but you just got to be careful with just it's something that people are starting to reconsider. I guess is a better way of putting it. People are starting to reconsider this just blast approach, but maybe some type of pulsative approach, maybe some type of, I know this is a theory of this press pulse therapy, where you have an underlying level of stress on the tumor level that is healthy for the regular body tissues that you want to keep stable and healthy, and then you pulse in with things that would take maybe that other cancer cells beyond the threshold of survival and lead into death. But we have a lot of theories out there, and a lot of work is still needed to further flesh this out. But that's why I feel lucky to have the job I have to be able to research these conditions and explore my passion in the Metabolic Therapeutics lab here at University of South Florida. And I don't know, it's a career based on curiosity. It's a career that also has major implications for people's lives, and I think it's very motivating. At a conference we hold, the Metabolic Therapeutic Conference, you get to interact with a lot of people who live this every day, and it's no longer like, oh, I'm sitting in a lab, I'm doing this research. It may mean, I don't know, I don't see it in my face, I don't see the difference right in my face, but at least you can see at places like this or other areas, you see the impact, because we're in a research lab, we're not, in a hospital seeing patients every day like a physician would be or an oncologist would if you're talking about cancer. So it's cool to be in a place like that to see the impact of it, but a lot of work to be done.
Absolutely, yeah. This conference has been absolutely fantastic, and thanks for all your work behind the scenes, and Angela and so forth for putting it together. One thing has come up and a lot is this question on the SARMs, and just kind of maybe be a little bit more relaxed. We don't know all the data on that, but there's a lot of individuals on the internet space that are influencers that are recommending these things, and we know that there's probably some receptor downregulation of the androgen receptors would be my guess. What are your thoughts in terms of use of this for hypertrophy purposes?
I'm super hesitant to say, oh, people should just go take this. Obviously, I'm not in the role to be that person to say that. I don't know is the answer, and we haven't, and I guess a lot of what's expected as a standard is like, okay, we want to see phase 3 clinical trials, and the reason we want to see that a lot of times and is because there have been times where therapies have worked in phase 1, they've worked in phase 2, and they don't work in phase 3. And so we always have to be so hesitant before we jump the gun and say it's going to work for everyone. However, if we're talking about a condition where there isn't anything else available to a patient, where they don't have much hope, I would just say if I was a patient, I would get a hold of something that can give myself a shot, even if it isn't completely fleshed out and completely known, if I don't have another option. So I guess it's context dependent. Would I recommend it? I would be hesitant to say anything like that. I don't know. I know a lot of I've heard in private communications from people who are like bodybuilders who have taken SARMs without much effect. If you're asking in the context of performance, I don't know. I've heard kind of wishy-washy results from something like that. If you're talking about for disease state, again, I don't know. Although it looks, again, has the potential to be the first drug ever approved for Cancer Cachexia. So it looks more promising than it wouldn't. But anytime you're looking at a phase 3 trial, you have a ton of people involved in it. And you may have people who actually really do respond to these drugs. And so if not everyone responds to it, maybe it's not worth approving it for phase 3, but is it actually worth just completely throwing out of the question because it hasn't worked for everyone? Maybe not, because even in science, when you see that bar graph, okay, where you have this bar in the medium of all the subjects, but you actually may have subjects here, 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 and this is your median. And people look at that bar and they think, okay, that's how people are going to respond. And I think on average, that probably will be how they respond. But what if you're that patient that's down here or way up here? That's something to consider, because you may be the person who hyper responds or doesn't respond at all. But again, it depends. That comes with a risk too if you're just trying things out. I know as a previous fitness person, I was much more lax on being willing to just, this supplement just came on the market, try it. Yeah, and I'm not saying that's the best strategy, but I'm also not completely lost in the fact that if someone doesn't have hope from what's currently available, I don't know, what does that person do at that point? And I don't have an answer for them. They have to make that as a personal choice. But I don't know if there's enough data to really indicate that it's going to be highly effective for everyone at this point, but we may find out it is in the future. But I had to be hesitant on giving a recommendation on that at this point.
Yeah, good advice. So let's kind of finish off with your personal tips. I know you've been lifting weights for quite a while, since age 12, I think you mentioned. You're a pretty big guy. At one point you squatted 500 some odd pounds. But your personal recommendation for what you found is your low carb and not always keto. Have you found more hypertrophy or maintenance of strength with a lower carb versus just straight keto diet? You want to kind of finish off on that?
Yeah, so as a type 1 diabetic, it helps to keep my blood sugar under control. So health first, right?
Yeah.
And even in medical practice, the number one rule is do no harm first. So health should be the priority, and so for me, managing good blood sugar levels is the most important thing. And so, yeah, I do a low carb approach. I think that helps me manage my blood sugars better. I've also communicated with many type 1 diabetics who are able to have phenomenal A1Cs doing that. Doing a low carb approach, I've had my A1C at 5.6, and it's been quite effective. I know type 1 diabetics who have way better A1Cs than I do, and there's a group called Type 1 Grit that has a small knit community of individuals who do this approach, and they support each other, and they have better numbers. There's plenty of people who have better numbers than I do. And so it's a really cool community. But as far as for athletic endeavors, it depends on the context of what you're doing. For me as a type 1 diabetic, just the more carbs I introduce into my diet, I'm not saying carbs are the worst thing in the world by any means. I'm definitely not saying that. And I definitely have their place in performance. We know that they have their role. Is a different dietary approach maybe better? Maybe, It's not like carbs are terrible, it's just something maybe better.
Yeah.
And that's, it's context dependent. There's different tools in the toolbox, so to speak, and it depends on when do you want to use the tool. For me, as a type 1, I do the low carb approach. I have done the ketogenic approach, and I've actually hit personal records on all those approaches. I just find that it's easier to do. What I do is I do powerlifting now. I have done bodybuilding before. I just find that a higher protein, moderate to high fat, just low carb, just allows me to feel really good in the gym and maintain that. I have done high carb, low fat, and right when I switched over to including more fat, I immediately saw a strength difference and improvement in my progression in athletic endeavors. And it probably is because I wasn't having enough fat in my diet, and the importance of hormones and whatnot, that I was probably suboptimal for a while. And so negating over and starting including more of that actually had quite a positive response. But that's something that I do. Each person will need to find that out for themselves. And if you have a way of maintaining your blood sugar levels that's effective, awesome, do that. Do that, it doesn't have to be this or that. Do what works. However, if what you're doing isn't working, maybe consider something where you lower the carbohydrates, because it may be easier. Because let's say if I used to eat 400 carbs a day and 300 grams of protein, a little over 100 grams of fat, and I would eat 4 meals a day, and that'd be 100 grams of carbs a meal. Let's say if I perfectly managed my blood sugar response in accordance to the insulin and the amount of food I was eating, that's fine, right? Not a big deal. However, if I miss time, or I miscalculate how insulin sensitive I am, let's say I work out and I have 100 grams of carbs after my workout meal. If I miscount or miscalculate the amount of how sensitive I am to my carbohydrates, the consequences get exponential the further you get in your carbohydrates. Because if I give, say if I have 100 carbs, I could range from anywhere from 2.5 units if I'm super sensitive, all the way up to 10 units for that, or more.
Wow.
And so let's say if I misuse 1 unit, that may not be a big deal. But let's say if I'm off by 5, that's a really big deal.
Yeah.
So the variability in your blood sugar as you get higher and higher may get harder to manage. And again, it's all about personal preference. It's all about finding out what works for the person. But I'll just say that's my personal experience. I've also communicated with many people who've had a similar experience. But again, it comes down to finding out what works for you.
Have you noticed other lifestyle factors like sleep loss? I know you've been very busy with this, and stress. Does that have a differential effect on how much insulin you need, or is it not as?
Yeah, it's kind of hard to think of what doesn't influence insulin sensitivity.
Yeah.
Lack of sleep definitely does. Like during this conference, there was multiple days where I got less than 5 hours of sleep. I got 4 hours of sleep a couple times. And yeah, it definitely makes me insulin resistant when I do stuff like that. Exercise influences, I noticed that for myself, the duration of the exercise, more so how high does my heart rate get for how long, affects my insulin sensitivity. Sleep, dietary factors, of course, exercise, of course, intensity and how many days in a row I do have exercise, of course. All these things play a pretty big role in insulin sensitivity, and like medications can play a big role. I know certain anti-inflammatory drugs taken over a chronic period of time, like corticosteroids, definitely can make you insulin resistant. Being sick can make you insulin resistant.
That's what I was going to ask. Like, how much more insulin do you need? Like, if you get the flu?
Okay. So
is it very significant or?
Oh, yes.
Really?
Oh,
Wow.
yes, for sure. So
Okay.
I would say that, here's a great example. I remember, this is the one that just pops right into my head. When I was about 5 years ago, I remember I got really, really sick, and just really, really severe cold, and I had a fever and all that stuff. I was tripling the amount of insulin I needed on a daily basis.
Whoa.
And that's not uncommon when you take like corticosteroids for extended periods of time, that you may have to take an exorbitant amount of insulin to compensate for either the dumpage of glucose into the system or the resistance associated with whatever the disease, not disease, but the illness and or the medication. So, or maybe both, because you're fighting one with the other.
Yeah.
So, yeah, there's definitely what's interesting about all that as a type 1 diabetic is I never really, I could see people seeing type 1 diabetes as a negative. But for me, working in a field of nutritional based therapies for certain diseases, I see it as the biggest asset of all time.
Yeah.
Having to manage my blood sugar and micro track everything I've done over extended periods of time and find out what does and doesn't affect blood sugar levels has been immensely insightful. I think that a high-level athlete would kill for the opportunity to learn as much about their body as type 1 diabetes forces a patient to learn. And again, if you don't want to learn that, you don't want to deal with that, yeah, it's a huge burden.
Yeah.
For me, I was in the mentality that at one point, I want to be as big and as strong as possible and look, have this ideal body image. And so for me, I was doing everything and anything to do that. And so these micro differences were everything to me. So I tracked everything. I used to count everything. I used to count every macronutrient every single day, saw how it responds to different types of food. All these things factor in. So, and to a certain degree, as a type 1 diabetic, you can do things to macro manage your disease, but you kind of have to start realizing the micro differences. So like with anything, if you're doing something to treat your health, you worry about the fundamentals first, okay? You do the things that make the biggest impact, and then you worry about the minor stuff more and more. And I got into all the weeds when it came into type 1 diabetes management for myself, and I learned a lot from it. So and it's honestly, I've talked to someone about this recently. They asked me, would you
trade it or take it away if you could?
Right, actually, yeah. I think maybe we were discussing
it wasn't
this.
us, but I can see,
Yeah, and I definitely was discussing with someone recently, and I would have to say no. I know that sounds crazy for some people. I mean, maybe at some point in my life, if there is some cure, I'll take it, but I wouldn't take it away at this point because of how insightful it is. I have the ability to acutely control my insulin levels and see how I respond to things. And that's a massive asset for stuff that we do in the lab if there's something we want to see if it does or doesn't affect certain your blood sugar levels or your insulin levels. I can see how things affect me independent of insulin levels. And just the level of information I've learned from it is just, it's priceless.
Yeah.
So I never viewed it, I got lucky in that I came from an exercise fascination background. So right when I got diagnosed with type 1 diabetes, I got hit with massive depression when I realized all the work. I was going to prick my finger every day. I was going to pull a needle out in front of people and inject. And they have other things to try and not force that level of stereotypical, like druggy type stuff where they have like things that look like pins and you just snap a cap on. And nowadays I have like this meter that meter, pump, or sensor and pump combined. That can kind of feed right in. It looks like a pager. I've actually had someone say, is that a pager?
Are you on call today? Yeah.
Yeah, right? I don't even know if they even use that for on call. Maybe they do. I don't know. I'm not a physician. But and so there's different ways of managing it that reduce the, I guess, outward negative perception someone gives you.
Right.
But a lot of that goes out the window. But I know some people are bothered by that, and I understand that. That's completely understandable. I used to be neurotic about what people thought of the way I looked, what I was doing. That was all so important to me at one point in my life. I care a lot less about that nowadays, and I'm sure because type 1 diabetes contributed to it. I still remember when I was in the gym after a workout one day, and I was pulling out a syringe and getting some insulin after a workout. And I remember this kid who must have been 14 or 15 years old walked by, and he was walking by, and there's different sections of lockers. And I was just sitting there pulling a needle out just like this, and this little kid walks by. He's like,
steroids. Yeah.
Right, exactly, right. So I I kind of chuckled at it, but I always wanted, like, man, I bet that kid's like, this guy's using steroids. Hopefully he didn't get the wrong impression. But it was kind of clear he did.
Yeah.
But you know, it's part of the management process. I don't blame people for not understanding it. We're all ignorant to something at some degree. I'm certainly ignorant to many things that I don't truly understand. And I don't blame people for maybe viewing it differently, but yeah, it's part of it. But yeah, I guess when you kind of look at type 1 diabetes, for me, it's been a huge advantage, not a negative. Kind of right from the start, only because I realized the potential to
Learning opportunity.
big time learning opportunity.
Yeah.
Especially for what I've always been passionate in, and the implications have actually been bigger now that I work in the lab I work in. I'm not necessarily doing it for my personal disease state of type 1 diabetes, but now the implications for blood sugar regulation may have far-reaching implications for other diseases. There's a lot of evidence to indicate that cancer may have an effect, Parkinson's potentially, Alzheimer's potentially. A lot of these conditions, blood sugar may play a role, not so much blood sugar, but like metabolism may play a bigger role than we thought. And as a type 1 diabetic, you are managing your own metabolism. You're playing your own pancreas of sorts, at least the beta cell portion of it. And so, yeah.
That's really fascinating. I mean, Andrew, that really speaks volumes to your mindset, your open mindset. You know, a lot of people have kind of this closed mindset, and you know, your ability to do this research and just insatiable curiosity, which is really fascinating. So I want to commend you for that. There's a great book out there, folks. We'll check out Mindset by Carol Dweck at Stanford.
Cool.
She talks all about that. And so you take the negative, what could be perceived as a negative, and you make the most out of it, and that's what you've done, which is cool.
Yeah, I think that on top of that, I'll also, you mentioned a book, I'll also recommend a book called Curiosity by Ian Leslie. I had a friend, a really good friend of mine, he owns a supplement company that tries to do better in the supplement industry, De Novo Nutrition, and he recommended, because we had always talked, when I was first joining this program, we became really, really close friends. And because we were just so enamored with learning at that point, and still one of the best people I know. And he introduced the book. He's like, man, I really think you'll love this book. And it just opened my mind up to how important curiosity is and everything. And a lot of times when people are struck with a bad experience, it could really be a terrible experience for a long period of time. But if you can take that experience and actually flip it into a positive, it could actually be a life-changing, one of the most impactful and positive life-changing moments ever. It depends on how you go about the process. And I've learned that from multiple things. With type 1 diabetes, I made it into a super positive. There's other experiences in my life where I didn't adapt to it in the same way, and I wasn't willing to change in that moment to really adapt and make it something that could be beneficial to me, and I suffered for a while. So I definitely, again, and this is a philosophy thing, but if you are willing to go into this and really just willing to do what you can to make the best out of it, it will totally change how the outcome of it. And the quicker you adapt to it, the better. Imagine if you were to go into a cold environment and your body doesn't adapt to the cold environment. How miserable are you going to be for a long period of time? Or say you're in a hot environment and you don't adapt to how hot it is, you're going to be miserable until your body is able to adapt to that. So the quicker you adapt, even mentally, towards something like that, the better. At least that's my personal recommendation.
Really good tip.
Usually these things aren't going away anytime. The type 1 diabetes ain't going away anytime soon. So it's just how you look at it a lot of times. So
yeah, it's that adaptation or resilience. So being able to overcome and surmount some of these obstacles is really a key. And a lot of successful people have had a lot of failure early on and just were resilient about that. And so one of the final questions that we like to ask every guest on the show, Andrew, is if you were to rub shoulders with a politician of sorts, maybe someone from the government, senator, House of Representatives, just had 30 seconds to share with them just a real poignant health or lifestyle tip that you feel maybe they could influence policy around, or at least should know about, so that we can improve the health of America, the world at large. What would you want to share with them?
Ooh, good question. The first thing that pops in my mind is I came from an exercise science background, and in that community, exercise nutrition is considered medicine. But it's certainly not considered that in the medical field as much. So the first thing I would say, just right off the bat, the easy thing is more initiative should be made on things that can be influenced without necessarily drug intervention. Exercise, nutrition, I think should play a more stronger role in what we're actually exploring and what their capabilities are in actually changing someone's health. because that could reduce, let's say you are able to actually change people's lives through that, you could imagine the exponential health care burden would be to reduce because people have it in their own hands at that point, and they aren't as reliant upon all the healthcare processes that treat it in a different fashion. So that's what I would say. Although I have to admit that I probably would just want to ask that person about why they do what they do on a regular basis. Usually when I interact with someone, I'm a little more intrigued about why they do what they do. That's fascinating part for me, is just wondering why do they care to do that? Like, what got them so intrigued about being a politician, and what makes them operate as a human being? Because we're not truly that different. Like the squirrel's running right by us, and there's different animals all over, and we even use C. elegans. I'm saying all this to show that we're so similar to so many other animals or different species. Genetically speaking, we're not that far off. And we notice that within biology, when we use model systems, we're using rats, we're using mice, we're using C. elegans, because and Drosophila flies, because their mechanisms by how they operate are so similar to us. We're not that different. If you, at least that's something that I've begun to realize when we look at this at a big picture perspective. And so I find it so fascinating how we as human beings, when we see each other maybe as so different, and I find that interesting. I don't know, it's something as a side interest of mine to just view into the philosophy of other people. It's something that's always been quite a curiosity of mine, but different talk for a different day.
Awesome. Andrew Koutnik, thanks so much for coming on the show.
Absolutely.
If people want to connect with you and your lab, where can they do that?
Good question. I don't really have a public page. I don't really do any of that, at least currently. Maybe I will in the future. I know my professor, Dominic D'Agostino, he has a website called ketonutrition.org for a lot of people who are interested in this type of stuff that we do in our lab, and also maybe some resources. That's a good place to go. Dr. Angela Puff is another person in our lab. She does have a professional Facebook page. I think Dominic D'Agostino does as well, and you could find them on Facebook. I mean, you can find me on Facebook too. I don't really do a whole lot of social media stuff at this point, but I think that Keto Nutrition is a good resource to find a lot of this information out there. And there's some other good people who communicate some of the stuff out there, like yourself. But for our lab, that's probably the best way to do it. And through searching through that, you can probably find ways to get a hold of us via email and whatnot. So.
Okay, I'll put the link below this video. So folks, if you like this video, please give it a thumbs up. I really appreciate you tuning in, and you can check out the show notes by clicking on the link in the description. Talk to you next time.